So let's do a quick little bit of review for cardio before we get back into it with what we are going to finish up today. So what is the main homeostatic variable for the cardiovascular system? Cardiac output, which is also known as Q. It means the same thing. It's just flow. Because it's flow, what are the units? It has to be a unit of measure over time. This is flow. How much of this can flow in a certain amount of time? So we know cardiac output is always liters per minute. So what does cardiac output equal? What are the two variables that make up cardiac output? Okay. Stroke volume. What are the two major determinants of stroke volume? How do you determine stroke volume? Minus your end systolic volume, right? End diastolic volume is a greater number. It's the amount of blood that gets into the heart right before all the doors close. That's your end diastolic volume, whatever's left over. Your end systolic volume is whatever is left over after systole, which should be a obviously lower number. What is the major determinant of end diastolic volume? Preload. So this is where preload comes into play. What are the two major determinants of end systolic volume? Not SVR. Afterload and contractility. Okay, so end systolic volume is determined via afterload and contractility, and your end diastolic volume is determined via preload. What determines our preload? Venous return. So therefore, blood volumes. More volume you have in the system, the more preload, because the more blood's going to come back to the heart. So preload, venous return, blood volume are all going to affect your preloads. Afterload. What are we talking about when it comes to afterload? What's the big thing we're worried about? Pressure, resistance to flow, right? So this is your systemic vascular resistance or total peripheral resistance. Same thing. Now, when it comes to resistance, okay, you guys like that boba tea stuff? I've never had one yet, but I know about it. Or like milkshakes. When you go to get a boba tea, what kind of straw do they give you? It's a huge one, right? Why? Because it's a very viscous material. You have to create the pressure, right? By you sucking up all that stuff. Try getting milkshake out of a coffee stirrer straw. How much pressure do you have to generate in your mouth to suck that liquid up? A lot, because it's a small radius of the straw. The bigger the radius of the straw, the easier flow is. So keep that in mind when it comes to learning about resistances. Just think about a straw. Okay, a big fat straw, easier to pull up. You don't need to suck as hard. But a very small coffee stirrer straw with a very, very small radius, increased resistance to flow, you have to generate a lot more force. Contractility. What is contractility determined by? What are the major influences of contractility? Muscle function, your Frank-Starling curves, right? Okay, so those Frank-Starling curves affects your contractility, the squeeze of the heart. If you've had a myocardial infarction, which means you had a lack of blood supply to a part of muscle in the heart, that muscle is dead. It's not going to regenerate. It's not going to squeeze again. So therefore, your contractility has gone down because you're losing muscle mass. You killed off part of the muscle. Therefore, the entire heart is weakened, contractility goes down. So all we did for the beginning part of the cardio part, just on the heart, was talk about these different variables. So hopefully this little cheat sheet now kind of puts things together. Why? And all those graphs that we drew, those pressure volume loops, is just to reinforce that. Remember, preload. What is it, a positive or an inverse relationship with stroke volume? Positive. So if you increase preload, you're going to increase your stroke volume. All those graphs just proves the point and reinforces it. I'm not going to ask you about the graphs. I may say if your contractility decreases, which way would the line shift? Same thing with compliance. Which way is that line going to shift if you strengthen or weaken compliance? Remember, a good compliance, what is compliance? The ability to hold on to a volume of blood without generating a lot of pressure. It's compliance. Think of a really good water balloon. You put water in it, it's going to expand. So preload, stroke volume for that. Afterload. What is the relationship between afterload and stroke volume? Inverse. So if I increase afterload, decrease your stroke volume. And again, why are we decreasing stroke volume with a higher afterload? What phase in the cardiac cycle do we have to spend more time in when afterload goes up? What part of systole? Remember, there are 3 phases within systole. Remember that Wigger's diagram. What is the first thing that has to happen in systole? Isovolumic contraction. And what's the purpose of that? To generate the pressure to overcome what? The aortic valve, your systemic vascular resistance, the total peripheral resistance. I'm spending more time generating force. And remember, this is a cardiac cycle. 60 beats per minute, 1 second per cardiac cycle. You only have a certain amount of time. If you're spending more time in isovolumic contraction, generating the pressure, you have less time for ejection. Because the heart's going to keep beating, that SA node is going to keep going, everything's going to have to repolarize and get ready to go for the next beat. So that's afterload and stroke volume. So the converses are true too. If you decrease afterload, you're going to increase stroke volume. So I didn't put all that in there. The last one is contractility. What is the relationship between contractility and stroke volume? Directly proportionate. If you increase contractility, you're going to increase your stroke volume. Okay? So these are the ways we alter our stroke volume. But remember, cardiac output is stroke volume times heart rate. So if our stroke volume is going to reduce, we want to keep our cardiac output normal. What has to happen to our body? Increase the heart rate to keep the number at 5. Remember, cardiac output is 5 liters per minute. That's a normal cardiac output. Remember, about 40 mLs, 50 mLs come out. 70 beats per minute, 70 times 70, whatever it is, 4,900. Okay, now we have the heart rate portion. How do we affect our heart rate? What 2 systems are going to affect our heart rate? And our sympathetic nervous system and our parasympathetic nervous system. Those are the 2 ways we can alter our heart rates. We can give drugs, but the drugs are just going to act on one of those systems, either adrenergic or, what's the other one? Adrenergic or cholinergic. Cholinergic is parasympathetic acetylcholine, parasympathetic. Your adrenergics are sympathetics. So SNS, what are the receptor types that we're going to be targeting? Alphas and betas. What are the types we're going to affect in the PNS? Muscarinic and nicotinic. Okay. Hopefully this kind of puts everything together we learned in cardiac as far as all these interactions, what's going to happen. Okay? Everyone good? I will print this and I'll put it on your modules. Okay? So I'll put this in a PDF and I'll give it to you guys so you have it on the thing. Any questions about that? PAs, when we get to cardiac pathology and pathophys in the fall, we're going to bring these pressure volume loops back a lot. So we're not going to lose them forever. Yeah, question?
So if you increase contractility, is that just like increasing the force of the contraction?
That's all it is. Yep. So we're going to squeeze harder. Now, she brings up a good point. When our heart squeezes harder, or we have a bigger stretch of the heart due to an increased preload, why is the contraction that much more forceful? What has our cardiac cells become sensitive to as we stretch? Calcium. So the bigger the stretch, the bigger the contraction, and it's all due to calcium. Okay, become very, very sensitive to calcium. Obviously, you know why calcium is important within the heart. Okay, so let's go on to, oops. Okay, we're going to finish up the regional blood flow and get into lymphatics and capillaries. Okay, so this is where we ended yesterday, or last week, with autoregulation. So, cerebral blood flow, and what other system need constant blood flow? The brain and kidneys. Just remember those two. Brain and kidneys need constant flow. So they have this process called autoregulation, so that over a certain map, blood flow will be constant. So that's what autoregulation does. If you're out of those ranges, you're not going to have appropriate flow through the brain or the renal system, and you'll have some problems with that. So cerebral blood flow, increased neuronal activity, and O2 consumption cause local vasodilation. So vessels are getting bigger in the cerebral circulation. Do you ever hear that? So those professional chess players at, like the really, really high level, they burn like 5,000 or 6,000 calories in a chess match because of the brain activity needed, because all the different processes, all the different moves that can go on, they burn a ton of calories from brain power. So hopefully you guys study more, lose some weight. So that's why you study more, it'll help. Okay, the next really important thing, this is going to help with when we get to pulmonary tomorrow. Arterial CO2, PaCO2, influences cerebral blood flow. As you start altering your carbon dioxide levels in the blood, you're going to have changes in the brain. Dizziness with hyperventilation, when you breathe really fast, is caused by cerebral vasoconstriction because we're losing CO2. When you breathe very, very fast, you're blowing off a lot of CO2. Have you ever seen people who do those long breath holds underwater? Before they go under, they're going, why? They want to get rid of the CO2 in their blood as low as possible so that you have a bigger bank to hold CO2. CO2 is what causes you to breathe, not oxygen. The lack of oxygen, you have plenty of oxygen in your blood floating around. That's why CPR doesn't do breaths anymore. Not because of the safety issue, but you have, out of the 100% of oxygen in your blood, whatever you have, only 20% of it is used by your muscles and tissues. You're still exhaling like 80% of the oxygen that you breathed in. So you have a lot of reservoir for O2. CO2 is the problem. When CO2 starts building up, bodies don't like it because it's very acidic. So that's why breathing really alters your carbon dioxide levels. If you breathe very, very fast, CO2 levels drop. You get vasoconstriction, and that's why you get dizzy when you hyperventilate. When you guys are doing your exams and you're having them listen to the lungs and you have them breathe all the time, We tell you to take a break because your partner who's breathing heavy all the time can get lightheaded and dizzy because they're dropping their CO2 levels. That's why we tell you just take a break, breathe for a little bit, and then start your exam again because you don't want them passing out. So that's where cerebral blood flow and CO2 comes in. CO2 is the main driving force for your breathing, not oxygen. It's the buildup of CO2 that causes you to want to breathe. And we'll get to that a lot more when it comes to pulmonary tomorrow. Renal blood flow. Renal blood flow has the lowest O2 extraction of major organs. It's not going to take a lot of oxygen out, which means it can get ischemic very easily. What's ischemic? Reduced blood flow. Ischemia is a reduced blood flow. Infarction means it cut off totally, and there's no blood flow past it. So ischemia just means lack of blood flow. So we need a very high perfusion for filtration. Again, that's why we need that auto-regulation. We need to have the kidneys being perfused. If they're not being perfused, what can't we get rid of? Waste products, excess water. The kidneys have a big role in water balance. So if you influence water balance in the blood, and we start losing a lot of blood in the urine, what happens to the blood in the body? Does it get more concentrated or more diluted? Concentrated in the blood. Okay, so we'll get to the kidney stuff a lot later. Not controlled by any metabolic factors. The kidneys are always just going to be perfused, and they keep going. As long as their blood's going into them, they'll be okay. Auto-regulation is here as well. Okay, over that map from about 60 to 160. Again, that's why our goal for a map is greater than 65 always, because we know the kidneys will not work if it goes below that. And how can we tell the kidneys aren't being perfused? What are you not going to create? Urine. Okay, so if we're not creating any urine, that means our blood is not perfusing the kidneys. There's no filtration going on. You get oliguria, reduction in urine production. During increased sympathetic tone, like during exercise, or during a baroreceptor reflex, okay, remember the baroreceptor, okay, will reduce mean arterial pressure, causing renal vasoconstriction. Does that make sense? During a sympathetic response, do we want to shunt blood away from the kidneys? Do we want our blood to go to the kidney when we're trying to run away from a bear? No, we don't want to pee. If the kidneys are being perfused, you're going to pee or create urine. So by increased sympathetic tone, exercise, we need some vasoconstriction so the kidneys aren't being perfused as much because we don't need it. We're in a sympathetic response. During extreme vasoconstriction, the kidneys can get some ischemic damage. What lab values will you see changes in if the kidneys are causing problems? Creatinine and BUN. Okay, have you guys gone over fish bones? Okay. There's a way to do your BMPs very easily. It's always the same. Sodium over potassium. I think bicarb over chloride. And this is BUN over creatinine, and here's your glucose. This tells you your electrolytes. This tells you acid base. BUN creatinine, kidney function. And then your glucose is obviously your sugar levels. So this is nomenclature across the board. Anyone writes a note and they write that fishbone on there, it's always the same setup. The bicarb at the top may change to a different one because they kind of correlate, but basically that's the way it goes. First section tells you your electrolytes, sodium, potassium. Why is potassium so important? What does it alter? Not the repolarization. Resting membrane potential. Yes, it will alter repolarization, but the big influence is that membrane potential is going to change. Okay. Splanchnic blood flow. What's splanchnic refer to? What does it refer to? GI. Pretty much your GI, your whole splanchnic is the whole bed of vasculature that goes over the entire intestines and all that stuff. Receives highest proportion of cardiac output at rest. Why? Rest and digest. We need more blood in the intestinal system to absorb all the nutrients you just ate and whatnot. Okay, and that splanchnic system is shared amongst the liver, spleen, and your digestive organs. Obviously, our sympathetic system has dominant control, dealing with vasoconstriction and venoconstriction. And obviously, if you eat something, the metabolism will go up because you have to digest whatever you just ate. And that's really all you're going to know for splanchnic. Cutaneous blood flow is referring to what? Skin, your skin flow. This is regulated in responses to thermoregulatory signals and general cardiovascular control of your mean arterial pressure. Okay, stimulation via pain, cold, fear, low MAP leads to cutaneous vasoconstriction. So blood flow goes to the vital organs. Remember, we can shunt blood away. Our body in a survival mode does not care about your fingers. You can lose your fingers and you'll still be okay. They care about your vital organs, keeping the blood in the core, keeping your core body temperature raised. Once your core temperature drops, causes hypothalamic activation of your cholinergic sympathetic efferents. This is with, increased core body temp. So obviously outside in Florida in the summer, very hot out there. As soon as you walk outside, you start sweating immediately, causing sweating, cutaneous vasodilation. When people's skin looks red or pinkish more than normal, that is from vasodilation of those capillaries causing the redness to happen. During a fever, again, shivering, vasoconstriction to increase our body temp. And then again, we learned about this in neuro. When the fever breaks, set point returns, and we cause sweating and vasodilation to get rid of the excess heat and to cool ourselves off with sweating. Skeletal muscle. Okay, obviously during dynamic exercise, 75% of your cardiac output will go to your muscles. That's called a muscle pump. That's why those bodybuilders will start working out before they go on stage. They'll do push-ups and all the other things before to get blood flow into their muscles so they look bigger. Okay, so what's going on there. Local metabolism, so the local events exerts dominant control. And it results in recruitment of capillaries that were not perfused at rest. You have capillaries that they're just there as reservoirs so that when the demand goes up, we have extra capillaries to feed all your muscles. But unless you're not using it, they're not going to be filled. Same thing with your lungs. We learn tomorrow about your lung zones. Your apices of your lungs right now have no blood in them. Why? Gravity is keeping all your blood down in your base of your lungs. Just gravity thing, simple like that. We have different regional distributions. But when you are exercising, what happens to your breathing? Goes up. We need more oxygen. We have more perfusion of blood into your lungs, so all those different zones start to fill up with blood now, and they're like our capacity. We have reservoirs of blood that can wait to be perfused with oxygen to feed our muscles. So when we need it, we can recruit more parts of our lungs to get perfused, more oxygen to our muscles, we can do more things. That's it on regional flow. The next up is talking about capillaries, this last little bit, and then we'll be done. So capillaries have the largest collective surface area for all of them. Oh, it's not coming up. Okay, you only have one aorta. So your aorta surface area is whatever the diameter and the radius of your aorta is. But you have millions and millions and millions of capillaries, and if you add up all those capillary diameters together, it's going to be a bigger area than your aorta, your arterioles, and so forth. So that's what it means by the largest surface area, and it allows for exchange of your nutrients and waste. Diffusion is the biggest mechanism for exchange. Diffusion takes time. The faster that blood goes through the capillaries, the less time you have for diffusion. And that's why it's so important in our cardiovascular system that by the time the blood gets to our capillaries, it's going very slow and low pressure. Because we need time for diffusion. If the blood goes too fast through the capillaries, you're not going to have time to deliver O2. You're not going to have time to get all your CO2 back out. You'll start getting problems. Obviously, lipid-soluble and gases will diffuse readily right through O2, CO2, very easily to go through. They're lipid-soluble or gases, they can go right through. Lipid-insoluble substances have low permeability to get out of the capillaries and are restricted to just physical openings. They're called fenestrations. So remember when we talked about when you have an injury, well, you don't even go through injury, but clotting processes and all that stuff. Those white blood cells have to get out of the capillaries. But normally, when our body is healthy, all these gaps in the capillaries are very, very tight. But when you have an inflammatory process in an area, those capillaries become leaky. Those fenestrations get wider, so white blood cells can get in there, macrophages, all that fun stuff. Your red blood cells can get in there. Remember, we need blood to heal. That's why diabetics have very, very bad ulcers and wounds on their feet. They don't have great circulation anymore. If you don't have any circulation, you can't heal anything. That's why you can't really heal cartilage and tendons. There's no blood supply. You can't get anything there. So it's always better to break a bone instead of spraining an ankle. You're better off breaking it because at least a break, there's tons of blood supply in a bone. Those will heal all the time. You know, that's how they figured out, they found these bones from 100,000 years ago, human ancestors. And they found that on their skeleton, their bones were healed, which means that they had some sort of society there that would treat sick people. Because otherwise, in the wild, they would have just died and moved on. But they found that bones were healed. They have callus formation, which means they have a society that was taking care of people. Anyway, we talked about this before. Time to diffuse depends on the velocity. And remember, blood flow is least in the capillaries because we can split all that stuff out. It's in parallel, not in series, so this pressure gets split out. So we have to talk about transcapillary fluid flux. We have to talk about movement of fluid for this. So the factors that determine it are just as important for understanding edema formation. When we talk about edema, there's one real major pressure that we're going to talk about, and that is going to be oncotic pressure. Oncotic pressure is the pressure exerted by proteins. So whenever you see oncotic pressure, it's proteins. That's what drives it. So the net fluid movement over a length of a capillary is a function of the driving pressure for filtration and the permeability of the capillaries. Are they being perfused? Yes. Do we have a way for this solid to get across? Are they permeable to it? Yes, then it can go and it can happen. We never want proteins to go into what space? I talked about it in the very, very first lecture. I said, keep it in your mind because it'll come out. Interstitial. We never want protein in the interstitial fluid. We need to keep it in the blood only. Proteins are big molecules, and because we have these fenestrations, normally you can't get protein out. But during problem times, those fenestrations get big, protein will start leaking into the interstitial space, and you'll see as we get through this segment what kind of problems that's going to cause with the body. So the net driving force for filtration is one part is your hydrostatic pressure. And what determines your hydrostatic pressure? Blood pressure or blood volume. The amount of blood in that area. Blood is exerting a hydrostatic pressure. Hydro is water, just think of fluid. In our case, it's blood, we're cardiovascular. So the hydrostatic pressure is the push, pushing fluid out. Okay? We don't want all this fluid to stay in the third space or the interstitial space. What's that going to cause if that fluid stays there? Edema. We don't want it. So it's opposed by oncotic pressure, proteins, and this is called, we'll call it the suck. Protein is going to suck the fluid back into the capillary, resisting edema formation. It's just the oncotic pressure. What's the pressure of the proteins in the blood versus the interstitial space? So let's change up some colors here. So there's our blood vessel. Here is the interstitial space. Okay, we have proteins floating around. Are there any proteins in the interstitial space? So in this example, we have the pressure in the capillaries, which is, let's say, 6. We have 6 units of proteins there. We'll just say it's 6. There is no proteins in the interstitial space because proteins can't move. Which way is water going to want to go? Into the capillaries. We're going to suck it back in because we have an oncotic pressure. There's protein in the blood. There's no protein in the interstitial space. Protein is not permeable, but water is. And that is the suck. The oncotic pressure is the suck. It's sucking that fluid back in. So if your oncotic pressure starts to decrease, because now either we're losing proteins in the blood, or we have leaky capillaries and protein is getting into the interstitial space, regardless, our oncotic pressure is going down. Where's that fluid going to stay? In the interstitial space, causing edema. There's a couple of things. Have you ever seen nephrotic syndrome in a child, where a child gets very, very puffy? That's because they're spilling proteins in their urine like crazy. They have no more oncotic pressure because they're losing all those proteins. So they fill up with fluid. There's no suck anymore. Liver failure. What's one of the main jobs of our liver? Make proteins. They make protein. What's the major protein that the liver makes? Albumin. Albumin is a protein made by the liver. Some patients who have liver failure, they're not going to make enough proteins. What happens to their oncotic pressure? Goes down. Liver failure, you'll see they have that big belly because they lost all the proteins. There's no more oncotic pressure. There's no more suck. So you start losing fluid into the interstitial space. So again, this guy Starling must have done a lot because Frank Starling curves, now we got Starling mechanism for filtration pressure here. So again, read the words carefully. It'll tell you exactly where we are and what we're talking about. You don't need to memorize this whole entire thing. Don't worry about it. One moment. Okay? What is important? It'll set up the equation. It'll make sense. Capillary hydrostatic pressure. P with a little c there. Big P stands for hydrostatic pressure. The little c says we're in the capillaries, which is your normal blood volume, the hydrostatic pressure exerted by your vessels. Force pushing fluid out. It's the push. Okay? Hydrostatic pressure is usually about 35 millimeters at the arteriolar end of a capillary. So you have a long capillary. Blood is going this way. This is considered the arteriolar end, and this is considered the venous end, because as you go along, you'll see what happens with capillary pressure in a second. So hydrostatic pressure is high here, but then it gets lower. Let me change the color of this. But as you get to the end of the line, hydrostatic pressure in the capillary goes down. Why does hydrostatic pressure go down as you go the length of the capillary? Well, where's that volume, where's that fluid going? If we're losing hydrostatic pressure, that fluid has to go somewhere. It's going into the interstitial space. Remember, hydrostatic pressure is very high. We're going to lose a lot of fluid right there. As we get towards the end, hydrostatic pressure starts to drop because we lost fluid into the space. Here's our interstitial fluid hydrostatic pressure, P with a little I. So that means now we are in the interstitial space. Usually it's going to be near 0. So it favors fluid movement into the interstitial space. High capillary hydrostatic pressure, low interstitial hydrostatic pressure. The flow will go from the capillary into the interstitial space with regards to hydrostatic pressure alone. Now let's talk about capillary oncotic pressure. This is a pi with a little c. So whenever you see pi in physiology terms, it's oncotic pressure, which is the pressure exerted by proteins. This is the suck. Okay, it's sucking the fluid back in. Okay. Interstitial fluid oncotic pressure, P with a little I. Remember, it should be very, very low because proteins really should not be there. So it should be very low. Let's put them all together now. Okay, here is our capillary, arteriolar end, the venular end. At the arteriolar end, hydrostatic pressure is greater than the oncotic pressure. When hydrostatic pressure is greater than the oncotic pressure in the capillary, we favor push. Okay, it's going to push the fluid into the interstitial space. Along with that, your nutrients, whatever else needs to get in there, your O2 will go and so forth, and then your fluid. As we get to the venular end, the oncotic pressure is now greater than the hydrostatic pressure at the venular side of the capillary. And because we're there, this is the suck. Net fluid reabsorption, net fluid filtration. So the filtration occurs at the beginning of the arteriolar end of the capillary. The hydrostatic pressure is greater than the oncotic pressure, pushing it out. On the venular side of the capillary, the oncotic pressure now is strongest, provides a suck to bring that fluid back in. So essentially, if all systems are working well, there really should be no net movement. So whatever you pushed out, if you pushed out 5 mLs, you should suck back in 5 mLs as well in a normal working environment. Everyone good on hydrostatic pressure? I'm not going to ask you to calculate it, but just understand hydrostatic pressure, if I give you numbers, it's just math. If hydrostatic pressure is greater than oncotic, push is favored. If oncotic pressure is greater than hydrostatic, suck is favored, and you're going to suck the fluid back into the capillaries. Okay? Any questions about capillaries? Okay. Lymphatics. Lymphatics is what saves us from the fluid buildup. The lymphatic system. It takes all that excess fluid, puts it in the lymphatic system, then usually it's going to go back into our venous circulation and get recycled that way. So lymphatic capillaries are found in all tissues except the brain and the heart. Everything else has lymph tissue associated with it. Permeable to fluid and protein, and that's the big part. Remember we said we don't want protein in the interstitial space. If it gets there, the lymph system will take those proteins out and pull them away so the oncotic pressure gradient goes back to normal. That's why lymph system helps resist edema formation. It gets rid of that protein in the interstitial space so that push and suck gradients are back to normal. Net formation about 3 to 4 liters of lymphatic fluid a day, and it enters the lymph and goes back into the venous system and your ducts. Okay? And then everything else I explained. So proteins that enter the interstitium from plasma are taken out by your lymph system. That's why a lymph system is so important. They think that a clogged lymph system can also not help, but it could be one of the underlying causes for cancer formation, because especially in morbidly obese people, all the weight especially in the groin area, there's a lot of lymph tissue there. If it can't get out, that's why some people get what's called lymphedema in the legs, because there's nowhere for that fluid to go. So causes of edema we've already gone through already. Most common, increased venous pressure, which causes what? Is that going to favor hydrostatic or oncotic pressure? Increased venous pressure. Is that going to increase hydrostatic pressure or oncotic pressure? Hydrostatic. This is a volume. We're talking about increased venous pressure. Means there's more volume of blood. Anytime we talk about volume of blood, it's hydrostatic pressure, P, in the capillaries. So, heart failure. Heart can't pump. So nothing's going out of the heart, but stuff is still coming back. And then you're going to fill up with blood in the legs because it can't get into the heart. If you have more blood sitting in your venous system, hydrostatic pressure goes up, the push. And if that push is really accentuated because of heart failure, all that fluid goes into your legs and you can't get it back out unless you give them other things. Generalized edema, we talked about this before too. Low serum protein, liver failure, we're not making enough albumin, nephrotic syndrome, where we just start spilling proteins into the urine. And there's no oncotic pressure for the suck. Everything is push, hydrostatic. You get edema and so forth. Here's your lymphatic blockage. Inflammation or sepsis also has problems, usually due to leaky vessels. Leaky vessels during like sepsis. Those capillaries are like wide open, everything flies out. Okay. So when you're talking about edema, where you have to look at the legs, this is a clinical correlation just to prove some things to you. If they have bilateral pulmonary edema, both legs are swollen, it's probably due to congestive heart failure. Heart can't pump, all the blood is pooling, hydrostatic pressure goes up in the legs, you get edema formation. With a deep vein thrombosis, we have a clot in one of the veins in the leg, not both legs, just one of them. Because we can't have any venous return in that leg, because like your greater saphenous can clog up that vein, everything below that gets stuck. So you get increased hydrostatic pressure in the leg because of the obstruction to flow, blockage. You have a thrombosis. You guys learned about clotting. So a deep vein thrombosis, a thrombus is a clot in the leg causing a blockage. You get an increased hydrostatic pressure only in that one leg, and you get one leg swollen. So if someone comes in and they have one leg swollen, start thinking could be DVT. If both legs are swollen, probably heart failure or something else going on, if that makes sense as a correlation. And we're done. Okay, cardiovascular system is done. Tomorrow we'll start pulm. Pulm goes along with cardio, it's not that bad. If you have any questions, please reach out. For PAs, what time is it now? 1:20. I'll tell Professor Perez to start at 1:45. Okay? So PA's anatomy at 1:45. If you have any questions, come see me.